And welcome, everyone. Good afternoon, and welcome to Mission Bay and UCSF. My name is Payam Nahid. I am a professor of pulmonary medicine at UCSF. I've been here for 25 years, and I now serve as the executive director for the Institute for Global Health Sciences. Today, we are gathered for the Bay Area launch of the pandemics volume in the World Bank's Disease Control Priorities series. It's entitled Investing in Pandemic Prevention, Preparedness, and Response. And just for everyone to know, for context, the World Bank published this book earlier this year, and we have had this opportunity to convene and assemble many of the chapter authors and editors to walk us through the lessons learned through that exercise and the approaches we need to invest in to prepare for the next time, which is the title of our event today. And yet, here we are, in the very midst of outbreaks that threaten health security worldwide. Headlines this month alone have focused on the hantavirus outbreaks linked to international travel, the emerging Ebola outbreaks of a strain that for which the vaccine and therapeutics are ineffective, and spreading in a multinational manner across DRC and Uganda. And alongside these acute events, we live with slower moving global infectious threats like tuberculosis and HIV, which kill more than 1 million people every year. So these threats should not surprise us. I don't think anyone in this room is surprised, I would imagine. They're neither unusual nor unexpected. In fact, you will hear today that the likelihood of another pandemic with global significance is far higher than societies are prepared to acknowledge. And that's one of the key elements of the chapter and the discussion today. The question is no longer whether there will be another pandemic, we know that. The question is whether we will choose to prepare before the next crisis instead of paying exponentially more for after it begins. And we've been in that situation before. And what compounds our situation is that these biological threats are already difficult enough to detect and contain and treat and prevent human harm, morbidity, and mortality, even without the headwinds of disinvestment in public health infrastructure, cuts to research and development, the weakening of surveillance systems, the retreat from multinational cooperation, which you'll hear more about in conversation, and this fragmented, isolationist, reactive approach will not work for public health. I assure you, it will not work for public health, global health, or human health. Because infectious disease know no borders. Ebola does not, hantavirus does not, HIV does not, tuberculosis does not, I could go on. So we've seen this before in the 2014-2016 Ebola outbreak, West African Ebola epidemic. There were 4 cases of Ebola in the United States diagnosed in country. Many of you know this history very well, but just to remind us that Congress enacted a $5.4 billion emergency fund funding package to support surveillance, hospital preparedness, research, international response. Prevention costs money, there's no question, and that'll be on the conversation we have today. But pandemics cost far more when you're reactive like that. And that's one of the key elements and lessons I took away. So the Bay Area has been long home to institutions and leaders who have shaped global health response and infectious disease. I want to especially recognize some of our leaders within the UCSF ecosystem, but I'm delighted this event is co-hosted by many Bay Area universities. I want to thank and recognize Kelly Taylor and the UCSF Center for Pandemic Preparedness and Response for their leadership in training and preparedness efforts. They were integral in the response to COVID, along with many colleagues in our community. I see George Rutherford here, Erik Gooseby, and many others who've worked to continue to strengthen health systems for us in preparedness for pandemics. For today's event, I want to especially thank Dean Jamison. Thank you, Dean. I want to thank Steph Bertossi, Victoria Fan from the World Bank, who I'm not sure if she couldn't make it, but Their leadership was instrumental in shaping this volume and organizing today's event, and thanking Stephen Birnbaum, our manager of communications and partnerships, who helped us organize the event. And then I want to thank our co-sponsors, Sarah Anderson from the Bay Area Global Health Alliance, Shuchi and Anand from UC Davis Global Health now. Congratulations and welcome to UC Davis. And Michele Barry from Stanford as Associate Dean of Global Health and Director of Stanford Center for Innovation. Look, I'm going to get off the podium here. We have an outstanding group of experts with us today, and I look forward to the discussion ahead. I would especially encourage you to pay attention, close attention, and close reflection on the conversation at the end between Dr. Rampele and Dr. Ashish Jha, who will, I think, there's a great deal we can learn from their perspectives and experiences that I think will be very complementary and will round us off for the end of the day, followed by a reception and some wine for everyone, because I think you'll need the wine after you learn what you're about to learn. Anyway, with that, it's my pleasure to introduce Michele Barry, who will moderate our opening panel. Thank you, Michele.
Good afternoon, everybody. Gee, what a time to be talking about preparedness and prevention about pandemics with what's going on in the news today with Hanna and Ebola. As Payam mentioned, I'm the Dean of Global Health at Stanford and the Director of the Center there. It's a pleasure to join you today for this amazing panel. Really, that is going to highlight key findings from the 4th edition of the World Bank's Disease Control Priorities. And this really is an edition that focuses on investing in pandemic prevention and preparedness. So one knows that COVID was not a black swan event. We witnessed that when we allow outbreaks to turn into epidemics and pandemics, the consequences really ripple beyond the hospitals. Pandemics can cause massive loss of life and huge economic disruption while profoundly shaping society for years to come. And you'll hear about that from some of our panelists. While outbreaks and threatening epidemics are unavoidable, our global response and preparedness to such outbreaks greatly impacts the risk of a pandemic, its severity, and its consequences. Currently, the African continent alone has over 200 disease outbreaks annually, and we're witnessing one that's occurring in DRC now with Ebola. Prevention and preparedness for these kind of events is what we're going to be discussing on this panel. Modeling, we'll hear from Nita, is really suggests, and I've been told that this is way too conservative by Ashish when we had an early discussion, but one of the prediction is that the next 25 years is a 50% chance of another pandemic, but we'll be talking about how I'm way too underrepresenting that. We face increased risk of globalization and development, facilitating the animal-human infections that spark zoonoses, as well as the transmission of interactions between disparate geographies. So to avoid these catastrophic events, we need strong local and national systems, as well as a coordinated international response. We saw the Hanna cruise ship epidemic that actually needed 3 continents to actually detect, monitor, and contain this threat of Hanna, which is a strain that, as we know, is uniquely transmissible between people. We now have a global pandemic agreement as of May 2025, the first legally binding global agreement that sets rules around how countries should act and collaborate to prevent and prepare for such pandemic threats, and doing so through a One Health approach. Yet this agreement still needs to be ratified, and ensuring financing and country-level policy to support this plan is absolutely critical to success. And as Ellen Johnson-Sirleaf and Helen Clark wrote in the June 2025 article, it will require hard work at the national level to ensure domestic legal alignment, technical capacities, and workforce strengthening. I'm looking forward to hearing from today's panel just how we're going to do that. We have fantastic panelists, and I'm going to ask them to come up, and I'm going to give you their bios. So I'm asked Dean Jamison, who is an emeritus professor in the Institute of Global Health Sciences at UCSF. In addition, Dean has been at UCLA, University of Washington, and the Harvard School of Public Health. He's also worked for many years at the World Bank as a research economist in many different sections. Nita, I'm going to ask Nita Madhav to come up. She's an accomplished epidemiologist and strategist with over 20 years of experience in health, innovation, and biosecurity. She is the former CEO of Biota, and senior director at Ginkgo Biosecurity, with a record of building data-driven infectious disease analytic solutions, leading international teams, and fostering cross-sectoral partnerships. I have to say, when I looked at your bio, Nita, I was very interested to see that you used to be the expert at CDC in special pathogens in hantavirus. So hopefully, maybe you can share a little bit of that. Erik, I'm going to ask Erik Hanushek to come up. And he is the Paul and Jean Hanna Senior Fellow at Stanford's Hoover Institution and one of the world's leading scholars in the economics of education. He's previously taught at Yale, the University of Rochester, and was the deputy director of the US Congressional Budget Office. He has investigated the impact of school closures on student achievement and has translated this into the economic and labor costs of these closures. And lastly, but not least, can I ask Eran Bendavid to come up? Eran is an infectious disease physician and associate professor at Stanford, as well as a faculty affiliate at the Stanford Health Policy. His research interests involve understanding the relationship between policies and health outcomes in developing countries. He explores how decisions about foreign assistance for health are made and how these decisions affect the health of those whom assistance aims to serve. So the logistic of this afternoon is each of the panelists is going to present for a very hard 7 minutes because we have a lot to say. And then we're going to open it up to Q&A, which I think is really key for this day. So I'm going to ask Dean to come up and talk.
Well, thank you, Michele and Payam, and thank you for making the occasion for this discussion. What I would like to do is three things. First, I'd like to put the disease control priorities series produced by the World Bank into a little bit of its context and purpose, to do that briefly. Second, to discuss in the context of the problems that we see today, the direction that the editors of this volume wanted to take it. What role did we think a volume like this could play in a world that is, on the whole, being pretty inattentive to the problems that the volume addresses? And finally, I'd like to mention just a couple of points in the volume that I think are important, but that will be relatively lightly covered in today's discussions. On the disease control priorities activity, this was established in the World Bank. Is that better? Sorry. So the disease control priorities work at the World Bank was established in the early 1990s in response to a global environment that was increasingly successful in dealing with childhood infectious disease, adult infectious disease, even under nutrition, but a world that was also facing two things with increasing clarity. One was the beginning of the AIDS epidemic, and the second was the much slower moving transition toward non-communicable disease being the dominant cause of problems, even in low and lower middle income countries. How, given the resource requirements for dealing with AIDS, for dealing with the NCDs, the successes but unfinished agenda associated with infection. How might one best establish priorities? So that has become, through a series of iterations of initially Oxford published books and then World Bank published books, moved to its fourth edition now. And what we're speaking to is the second volume in the fourth edition of the World Bank's Disease Control Priorities. There are two more volumes still to come out, probably several years from now. That's the background. Like I think everyone here, the editors of this volume and the people we were dealing with at the World Bank who wanted to see it come to light have been deeply concerned at the rapid diminution of any serious attention to the pandemic risk in the immediate aftermath of COVID-19. So we made a list of some of the kinds of things that would ideally occur in terms of domestic resource allocation, domestic preparatory activities, international cooperation, international finance. As we went down that list, we were increasingly discouraged at the lack of progress in most places. A cup really half empty, at least half empty. But at the same time, there are governments, there are institutions around the world that are paying serious attention to pandemic risk. And what we decided to emphasize in the work that we did that with the authors in the volume is to address that community of people, not to particularly address the Biden, much less the Trump administrations, or the international organizations, but rather to address countries, maybe mostly in the Western Pacific, but not entirely, that were interested. What lessons could be drawn, the sort of modeling that Nita does, from the retrospective looks that have been undertaken, thoughtful, careful looks at COVID-19. What could be learned from those for a government or for an institution, research institutions, that was seriously interested in making a difference? So our volume is oriented to those that care. A couple of comments on the volume. I personally was very strongly influenced by the Japanese editor of the volume, Hitoshi Ashitani. Hitoshi was an epidemiologist, virologist, and was a key designer of the very effective Japanese response to COVID-19. He's emphasized several things. One, that an influenza pandemic might look very, very different in a lot of ways that we all can speculate on, look very different from the coronavirus, but we were paying, in his view, excessive attention to lessons from the coronavirus. More important in my thinking was his emphasis that probably the success with vaccination in coronavirus may well have been an overly optimistic signal into the world community. Next time, we might not have a vaccine nearly as soon, or nearly as shortcomings of the vaccine, certainly, but not or nearly as effective. That puts the important responses before the pandemic, as Payam was emphasizing on prevention, the important responses after the pandemic begins into interruption of transmission through the mechanisms that were very successful in some countries and totally unsuccessful in other countries in COVID-19. And it puts great responsibility into the clinical medical system to keep people alive who are affected by the virus. And we'll hear more about that from Shuchi and Anand later today. But to me, that was the importance of clinical medicine, the importance of isolation, and the importance of not relying too much on having a vaccine. Those were some of the lessons that I think I took away. I hope we can discuss. Thank you.
Hello, everybody, and thank you all for being here today. I wanted to talk to you a little bit about the second chapter of the Disease Control Priorities Volume 2, which pertains to methods that we use to estimate future epidemic and pandemic risk. And so one of the key messages of that chapter is the risk remains high. And thank you, my talk is now over. No. So there's maybe a few points to note about that. So the approach that we took was because we needed to quantify what that risk is. And the results that we developed have been used to estimate the potential economic losses from that level of risk. We chose to focus only on directly caused mortality from being infected by the pathogens that we modeled. And so we recognize that there are many other types of outcomes that are not captured. So for example, hospitalizations or long-term sequelae are not captured in the numbers that we estimated. And we used an approach that is not necessarily often used in public health, which is to combine a catastrophe modeling or extreme events modeling approach that's more often used for natural disasters and in actuarial science, combine that with epidemiological compartment modeling to estimate hundreds of thousands of potential scenarios to come up with the estimates that I'll talk about today. And we decided to take this approach because it allows us to simulate a lot of different input parameters and to come up with a wide range of plausible scenarios. So we're not just tied to events that have happened in the past. We try to get away from having recency bias to looking at only the most recent events to try to understand what the full range will look like. Now, with that said, because we also had, we didn't have infinite amount of time to do the work. So we chose to focus on particular pathogens that we know are of a high risk for causing a future pandemic. And those include pandemic influenza and emergent and novel coronaviruses. So running our estimates through, and there's a lot of information in the chapter and in the appendix. So if you're really into the modeling details, I encourage you to check that out. So the first number I'll tell you is 2.5 million. This is our estimate for the average annual losses from an epidemic or pandemic of influenza or coronaviruses. What does that even mean? Well, what that means is we're not talking about that every year there'll be 2.5 million deaths from these epidemics and pandemics, but rather what we're looking at are large spikes that occur more periodically. And so, every 10 years, every 20 years, you'll see these large spikes, which have different implications than an event that would be happening every year and having 2.5 million deaths, mainly because there will be considerations of surge capacity and health systems can be overwhelmed when you have these large spikes. So that's 2.5 million estimated deaths on average, if you average over these long time periods. And that's actually comparable to what you would see with pneumonia deaths, for example, that happen every year. So that tells us that this risk is on par with others that are currently out there and do deserve that level of attention as well. The next point I'll make is that in our modeling, we also looked at regional capacities and capacities by country, both for the current levels of preparedness, as well as access to different medical countermeasures, the ability to respond. All those types of metrics are captured in our modeling approach. And so we find that there is great regional disparity in how countries and regions will be affected by future epidemics and pandemics. And so there's a wide range. We see, for example, parts of Africa and Eastern Europe are at the highest risk for future mortality from these events. The third point I'll mention is, and to Dean's earlier point as well, is the age distribution of a future pandemic may look very different than what we saw in previous influenza pandemics, as well as in previous coronavirus epidemics and pandemics. So while most of the focus has been on the elderly population being at high risk, or even children being at risk from other types, from influenza especially, there is a potential for middle-aged people to also be impacted by these pandemics, and that will have different economic implications. So one other thing to keep in mind. The fourth thing I'll mention is the number that comes up a lot, which is that over the next 25 years, there's a 50% chance of a COVID level mortality event or greater. Now, I'll say a few things about that. We consider this to be a lower bound estimate because we are only considering naturally occurring coronaviruses and pandemic influenza viruses. So we know that there's a lot of other potential causes from different viruses, different bacteria, but also from man-made threats, including both accidental and deliberate. So that's another thing to consider and a very important emerging risk to keep in mind. But one other thing I'll say, I always like to end on saying it's not all doom and gloom, because we actually have the opportunity to move these numbers. And so we have looked at what would happen if the risk decreased over time. Then it's not going to be 50% chance over the next 25 years. But if we go on the wrong trajectory and the risk increases, let's say it increases by 5% every year, then we're looking at something closer to a 70% chance. So I don't think anybody wants that. And we do want to make sure that we're putting the needle back into the other direction. But we really do have the opportunity to make improvements to that number. And with that, I'll turn it over to the next speaker. Thank you.
Well, I appreciate the chance to be here. You will soon find out that I am a very odd person in this room. I know nothing about health. I'm going to talk a little bit about the economic cost of what we saw in the pandemic, and in particular about the costs that come through school closures, which was one of the issues that came up and was pretty well ignored during the pandemic, and since then has not picked up any steam. I have three observations from looking at the school closures. The first is that there was a huge underestimation of the length of school closures at the beginning, and that led to all kinds of bad outcomes. Secondly, there was a unbelievably large underestimation of the cost of school closures. And we're still paying for it now and well into the future. And there was a huge overestimation of the possibility of recovering from these school closures that we had. So let me just give you those results. There are some pretty pictures here that were once slides, but I will try to describe them. If we look at the beginning of the pandemic in March of 2020, there was a survey done of countries in the world of how long they expected the problems to last from COVID. 65 countries thought this was a 1 to 2 week event. Another 47 thought it was a 3 to 4 week event. And only 11 thought it was 5 or more week event of those who answered this survey. And this is not a problem of just all the countries in sub-Saharan Africa that didn't know anything. This was, in fact, the worst estimates in some ways were by the high-income countries of the world. If you look at the reality of closures, I think everybody has a vague understanding of what they were. In sub-Saharan Africa, schools on average closed for 220 days. Uganda, I think, took the world record of over 2 years of having schools closed. Latin America was the worst of all the regions of the world, with over 400 days of school closures on average. Now, what happened in all of the discussions that I saw, or my observations, is that people thought, well, we'll just make up for that. We'll go back to school and fix everything. In fact, if a kid misses half a year of schooling, on average, he or she can expect 4% lower lifetime earnings. 4% lower lifetime earnings from a half-year closure. And it varies by the amount of closures. But there's a bigger cost too. What school closures do is lower the skill level of the country, basically. Kids don't learn as much because of the closures. As a result, the labor force has less skills. And by having less skills, it means by historical work, partly with the Jamison clan on economic growth, the country will grow slower. Economic growth is what determines the future well-being of the country. And it turns out that the skills of the population have a huge impact on economic growth. So that a half year of school closures means has a present value of roughly 1 year of GDP. So for the US, a half year, if on average schools were closed for a half year, you're talking about a cost of $30 trillion. Okay, or if you average that over the rest of the decade, it would be something like 2.2% lower GDP than we would have had without the pandemic. Now, these costs, it's hard to put $1 trillion into perspective. One way to think about this is that it's 8 times the total cost of the 2008 recession. Everybody talks about the importance of this great recession in 2008. 8 times that cost from the school closures, borne heavily by the youth, but also by the rest of the nation. So that's the backdrop of lots of my work is involved with trying to improve the level of schooling so that we can have development in different parts of the world. In simplest terms, at the current level of education in sub-Saharan Africa will never, ever develop. It does not have the skills to operate a modern economy. And so that's the backdrop that we had before the pandemic. And then you add on 2 years of school closures in Uganda, and you see that we are in worldwide problems. So what are the lessons? It appears to me that at least at the COVID times, we didn't have a clear decision model on how to weigh costs and benefits of things like school closures, things that were outside of the areas of most of the people in this room who are interested in the health aspects and so forth, hospital costs, and you go down the line. But there are these ancillary costs that are huge, and you have to have some way to balance the closures in the schools against the risk to the teachers of infection, or the risk to the kids themselves, which appears to have been fairly minor, fairly small risk to the kids. Secondly, the impact of having inaccurate data, but particularly of never updating those data, is really an important issue. And so with a bad model that is never updated, you end up with costs that are 8 times the 2008 recession.
Well, thank you, everyone. I was asked to come here and reflect on the panel, and so I will provide some reflections. But before I do that, I really want to give a huge kudos to Dean and the entire DCP community, really, for this enterprise that has been going on, for a long, long time. And for me, one of the more remarkable achievements of the DCP is really being able to find a middle ground away from things that are kind of at the extremes, finding middle grounds that are grounded in sensible reasoning and information to make kind of good decisions and good policies. That's been something that I hope carries on into many, many years into the future. So I'm glad to see this the DCP continue and happy to be part of this. Okay, I'll provide 3 general points that I kind of was struck by when hearing the panel. And I think part of the reason why they invited me is that I can sometimes be a little bit of a gadfly, so I'll try to live up to that reputation. So I'll talk about indexing, learning, and policying. Okay. I think a couple of times we heard this notion that, the next pandemic may not be the same as the previous one. It is indeed, both tempting, but also deserves caution to not over-index on COVID. COVID is obviously very salient, but at the same time, the next pandemic might look extraordinarily different. A lot of the things that we learned or that we thought we knew how to deal with in a pandemic turned out to be ineffective. A lot of the things that we didn't know we did not expect a vaccine to happen so quickly. We're surprised, and that may not be true in the next pandemic, as Nita mentioned. Now, similarly, not to over-index on things like the losses. So the things we learned from COVID about the effects of school closures, that was that definitely, I think there's wide agreement on the harms for schooling, the increases in inequalities, the unique harms for places that were closed unnecessarily for a long time. That may not be the case. Again, this is something that depends. I think COVID spared the children by and large. On the other hand, if it had not spared children, I think the calculus for what would happen with schools would look very different. And an influenza pandemic may look very different on that. So I would be curious to hear how people think about how you try to not really over-index in trying to think about and plan for the next pandemic and think about preparedness. Okay, learning. The risk of future pandemic is high. I love that, and that is surely true. And then if a future pandemic is coming, which I think pretty much everybody would agree, yes, the future pandemic is almost certainly coming. We have to learn. We have to learn fast when the next pandemic comes. Right? Learning that. Learning about how to respond, what are the key epidemiologic risk factors is indeed something that needs to happen very fast. It didn't happen quite, I think, as fast as it could have during COVID. And look at me, I'm over-indexing on COVID. But at the same time, I feel like that is one of the key things that we can do in response to a pandemic. Similarly, also learning about the harms, of course, that we did not learn about the costs of the social isolation and the school closures fast enough, I think. There's also a question about how to learn and what to do during this kind of internecine, interpandemic period. We're not at a period, we're not at a time of acute stress. Now is the time that we can learn a lot of things that can be useful for pandemics. I think a big one is going to be technologies that are going to be useful for pandemics, vaccines that are going to be for many strains of influenza, ventilators, HEPA filters that are going to be even better, that are easy to deploy, that can potentially be cheap enough to be deployed widely in low and middle income countries. These are all things that I think are crucial for us to do. And so learning is again something that we heard from everyone here, and as a key lesson. And then the question of what to do with policies, the policying. I agree, and it makes sense to kind of speak to the folks that care, and I think that's certainly a very important concern. However, I think that we have to also be cautious about the effects of policies writ large. In fact, there's one of the lessons that again we might have seen is that excessive pandemic response may have undermined future pandemic response, and the extent to which kind of going at the policy level is potentially undermining future responses is something that we have to think about and be cautious of. I will end with saying that again I appreciate all the various thoughtful remarks. I think that this is an area that is extraordinarily ripe for learning, especially now during a time when we're not in acute stress. Thank you very much.
Thank you, Eran, for your gadfly wrap up. I'm going to open it up to Q&A, but I'm going to take the liberty of asking the first question to any of the panelists that want to take it on, because I'm not usually U.S. focused, but with the pullout of the U.S. from WHO, with a government administration that is not paying any attention to pandemic preparedness or prevention, what route do you think we should take? And while we're at it, we can throw out vaccine skepticism and misinformation. How do we go forward in pandemic prevention? Dean, I'm going to call on you. If
Dean, you got to pop
Yeah. Well, thanks, Michele.
Sorry.
Sorry. A couple of quick thoughts. So on the latter points you raised about disinformation, vaccine skepticism, and I think they relate a bit to what Eran was commenting on in terms of learning lessons and failing to learn lessons, over learning lessons maybe, and that is that paying attention to the information needs of the part of the population that really will use and care for information seems to me to be the central role that we in the technical community can play. Getting our message technically correct on prevention, on clinical management, as quickly as possible, and then having that serve the needs of people that care. And for those that don't care, yes, we need to pay attention to the vaccine skeptics at some point, but I'd worry about the people who want the vaccines and can't get them a lot sooner.
Nita, or?
Yeah, so I'll respond to that. I think that was spoken like a true economist. Coming from a public health standpoint, that is my background. I do agree that it's harder to reach some people with the messaging, but I think there's a lot more that the public health community can do to communicate when it comes to uncertainty. What do we know? What do we don't know? I think that's something that we can do better at. And I also think we can do more instead of being kind of that expert who seems removed from the community, to really enlist more trusted voices in trying to communicate with the general public.
Eran, you want to take about the WHO pullout and how slow CDC has been to react to any of these outbreaks currently?
Yeah, I mean, I think WHO pullout has been, it's been a huge symbolic move for the U.S. to pull out of the WHO. I think. Okay. Yeah, I think that in some ways it's a call to try to find different mechanisms and different pathways to generate global coordination. I mean, I think broadly speaking, we are in a global era of general isolationism and not so much about cooperation. I think that the withdrawal from WHO, with the withdrawal from the lack of agreement to the pandemic pact has been. These are all symbols of that kind of general lack of cooperation. My general sense is that, again, I think maybe close to what Nita was saying, is that we have to make the positive case for the benefits of what public health can do. I think that can provide the case for global cooperation.
Questions from the audience? Mike.
Yeah, I have a question for problem. Your insights are fascinating.
Sorry.
Hoover said corruption.
School closure. And if I correctly remember, $30 trillion lost in the US economy from 6 months of closure. So I guess I'm curious, as you think about pandemic preparedness, how much investment should go into keeping schools open, and how does one frame those huge lifetime economic costs against the other costs on society from a pandemic?
So I think the larger lesson is that all the attention went to basically public health during COVID, and that there are these ancillary things like schools. My own view is that the future of the country depends upon the quality of its education today, because that determines the labor force tomorrow and what will happen in terms of economic growth. The things that we learned, and we're learning more now, but we learned from also past other incidents, is that kids don't recover. Has been this argument that kids are resilient, they'll just pop back up to where they would have been, and that's not the case. It's also not the case that adding on little bits of remedial things, like a little bit of tutoring or maybe a few Saturdays of school, is going to make up for these costs. So that people have to come into it realizing that what you do today has huge implications for the economic future of the country. And I think that that's a major issue that the U.S. is going to have to confront. I'm mainly a U.S. Economist, and the U.S. is in decline unless it improves its schools, and things like pandemics just make it worse. I'll just add one final comment. The one advantage the U.S. has that nobody else has is H-1B visas. We just bring in talented people, and so when I live in Silicon Valley, you can get any ethnic food there of people that are doing the future of technology.
Problem is those visas cost a lot of money these days. Other questions? Yes.
So hi there, my name is Emi O'Brien from University of Tokyo, and I also work closely with series editor Hitoshi Oshitani. So I'm going to take the mic for Gen Z here at the moment. So for context, during the acute phase of the pandemic, many of us, we were either high schoolers or undergraduate students, enduring the pandemic and during school closures. And we're kind of at this point in our careers in kind of a listening and learning point, maybe contributing to some research. But many of us are very, very early career or very, very early in our schooling, perhaps maybe starting PhDs and master's programs or medical students. And so when I look at pandemic projections and I look at the timeline, I think, well, those of us with this lived experience who are investing a lot of our education and learning, we're probably not going to be like maybe 20 years from now. Maybe some of us will be in consultant positions, but we will likely not be in major decision-making positions. So my question is, for those of us in our age who are very, very early career, what can we do to support pandemic preparedness with our current capacity, as early as possible?
excellent question. You stumped me out.
Yeah.
Is that okay? Yeah, same. As I introduced the orientation of the editors of the volume to their audience, it was an audience of governments and of institutions, some universities or foundations, international organizations, institutions that cared, governments that cared. And that reflected a deep pessimism in terms of responding to your question, a pessimism about what an individual can do in an environment that is not listening. In the US today, in the US under the Biden administration, I think in the WHO, not necessarily WHO's fault, but it can't put together any shred of the money required for preparation. The pandemic agreement is not toothless, but it's not much either. It's really not much. I'm just saying that I don't have an answer unless you live maybe in New Zealand or China.
Maybe I'll just add to that. I don't know if this may be a little bit cliche, but I think Gen Z may be in a great position to do more to counter misinformation. You all know how to use that social media better. I'm saying that facetiously, but I think there is this opportunity to harness newer technologies that people who are a lot of times in policymaking position may not be as familiar with even what's possible with it. And so I do think that there's some role to play to help bring public health even and our pandemic preparedness efforts into the new century where we're in.
And I'll just maybe just to take a slightly different. I'm optimistic for you guys. I have two Gen Z daughters, and I'll say I think that the kind of your ability to kind of adapt and learn, and the kind of the changes that are upcoming for with whether it's new biotech, new changes in medical technology, as well, of course, AI. All of these things are the ability to learn and to adapt and to kind of develop new technologies that are going to be extraordinarily salient from pandemic preparedness. I think it's going to be it's going to change radically.
So I had a question, but I'm actually going to answer your question as well. And we'll talk about this a little bit later. There's been an unprecedented attack on the sort of standard global world order, WHO, countries, universities. And I have felt that most of these institutions have been incredibly pathetic in their response. And so I would not look to these institutions for hope. And I have an incredible amount of hope, but it's actually from people like you. Because my view is that, and sort of building on the last comment, pandemic preparedness is not policies set in Geneva. My God. Like, we have great policies. We have international health regulations. We have standard things. All of those get thrown out the window when there is a crisis and people are dying. What saves us is real innovation, strong health systems, engaging the public. And there is a ton of work to do on pandemic preparedness. And I wouldn't look to DC and I wouldn't look to Geneva. I would look to the next generation of people to build the tools that we need. So don't look to us. We're the old guys. Because we're looking to you for the solutions.
Yeah, and I think your voice is very powerful. If you look at some of the geopolitical issues that are happening, like in Nepal, it's been the Gen Zs. If you look at the climate activists, it's been the Gen Zs. Your voice is very powerful to make a difference.
All right, now I'm going to ask my question.
Oh, I forgot.
Sorry.
I would never keep you quiet.
No, sorry. And I just had to, because it's such a great question. I felt like the last thing I want you to do is feel down, because your optimism is what at least keeps people like me going. I would love it if we could talk a little bit about the pandemic accord. It's gotten brought up a few times. It's the first kind of global effort to do something after the pandemic. we're a year since we kind of concluded, and then we were going to have all this stuff on pathogen sharing. I have my own thoughts about the pandemic accord, which I will not share. Maybe I can do it later. But I would just love to hear from all of you. What does it tell you about multilateralism, the ability of multilateralism to move substantive, important things forward that will be useful in the next pandemic, whenever it arrives?
Make a sort of a side comment to that. At the Hoover Institution at Stanford, our director, Condoleezza Rice, has been pushing the entire institution to think about what follows on to Bretton Woods, the UN, IMF, NATO, and all of these institutions that are no longer what they were in 1954, or whenever you want to choose it. And I don't think we have an answer to that, because we have a failure of the old system that was very effective for 50 or 70 years, but that system is not going to be repaired. And so I think this general question of whether you can sign a document like the UN Charter and expect it to have some impact is questionable right now.
Does anybody else want to? Ashish, I'll push it back to you. I mean, I'm sorry, I'll take your question, but give me 1 second. The international health regulations are crucial. I mean, pathogen sharing, crucial. So if we can at least put a little bit of teeth in that accord for those aspects, we need to do that. I agree, there are a lot of compromises. Question next to, I'm sorry, I don't know your name.
Thanks very much.
Identify yourself, though.
Thanks very much. My name's Rob Bradley. I'm not a health expert at all. My expertise is in the climate space. But I have a question particularly for Niti, and thanks very much for sharing your analysis. I'll probably frame this question in the most irritating conceivable manner for an analyst, which is to say, I haven't read your chapter, but in a nutshell, the probability outlooks that you were laying out for us, do you have some sense of how different those would have been if you'd published this 20 years ago? Are we seeing an increase in the probability of these pandemics? Is it holding steady? Do you have a sense of what the drivers would be? Is climate change impacting that? Is increased population density impacting it? Are more of us making sweet, sweet love to Wuhan bats? Like, do you have a sense of the drivers and what you can tell us about how that outlook might change over time?
Well, that's a great question. So I'll first start by saying our forward-looking estimates, the 25-year estimate that we often talk about, that's actually assuming the risk remains constant over the next 25 years. So that is a big assumption, and we think it's probably not even a great assumption given the current, what's currently happening. There's other research that's not in the chapter, but I can send you some of that background work that does show for certain pathogens that the trend is actually showing an exponential increase in the number of events and the amount of mortality from those events. Now, the drivers are more difficult to elucidate because there could be many. This is mainly an ecological type of analysis. So there could be factors related to improved diagnostic capacity could be causing some of this upward trend that we're seeing. But we also think there's likely to be some impacts from climate change and anthropogenic change especially. And I don't know if there's a panel on this later. One of the other panels may address this, but there is evidence for that. And so it is something that we aim actually to, in ongoing discussions, we're looking at how to link these pandemic risk estimates to what we're seeing in the climate change community as well, to try to marry these two estimates and have a unified projection.
I think we'll take one. Can we take one more question? The lady in the back. Do you need, I think we need a.
Hello everyone. Thank you for your little intro. My name is Yashleen Sharma. I work at the IHPS department, and I'm a millennial, but I'm also in my early career as well. I mainly work on multi-drug resistant tuberculosis, especially doing the cost estimation, resource allocation for the high burden, low income, low LMIC basically countries. My question is basically I'm using World Bank indicators just such as GDP per capita and the CPI values for the healthcare cost across countries and trying to do the cost estimation for some of the medical resources of tuberculosis. However, I saw that the data sets are only available through 2024, I believe, in the World Bank, or maybe I'm looking at the wrong website, but I'm also trying to understand how their role in forward-looking epidemic or health system modeling, for example, how can we predict using the values from 2024, how can we predict the future projections through these scenario analysis, or are there any better approaches or incorporating economic uncertainties that you can suggest in this case?
I think it's in some sense a good accomplishment that the bank's numbers are as recent as 2024. So my concern with World Bank's finance numbers concerning health is not a concern so much as a sense of incompleteness, and that's a demographic incompleteness looking ahead a decade or two. The demography of increased demand on health systems from aging populations with expensive conditions, and equally important, the hollowing out of the middle age of most populations, undercutting the tax base, but also undercutting the care base of people who can take care of older people, increasing numbers, and that those are the essential financial questions that will be, I expect, putting a lot of pressure on capacity to deal well with multi-drug resistant tuberculosis, to take your example.
So with that, I'd like to thank the panelists and thank Dean very much for putting this panel together. And I look forward to the next panel. Thank you.
Good afternoon. My name is Mike Reed. I'm faculty in the Institute of Global Health Sciences. My pleasure to host this second session. I think you all agree with me that was super fascinating. All of those presentations that we just heard, I think, really rich, and we could have sat and listened to more conversations. So thank you to the panelists from the first panel. Slightly different format for the next 45 minutes. What we'd like to do is make this a little bit more discursive. I'll ask each of our panelists a question, a follow-up question. We'll go around a couple of times and then open it up for questions from the audience as well. Again, as with the first panel, our goal is to have them share insights from the chapters that they co-authored from DCP4, and really grateful to have Steph Bertozzi as one of our panelists and editor who can help synthesize and summarize across the different work streams. So I'll just prime him that I'm going to ask him the first question. But before I do that, let me introduce our amazing panelists to you all. So to my far right, Professor Shuchi Anand. She's the Associate Dean of Global Health at UC Davis. She's a nephrologist whose work focuses on acute and chronic care systems, particularly among medically vulnerable patients. Welcome, Shuchi. Dr. Angel Desai, also from UC Davis. She's an infectious disease physician and epidemiologist at Davis whose work focuses on displaced populations, outbreak surveillance, and communicable disease governance. Steph Bertozzi, Prof. Bertozzi from UC Berkeley, probably needs no introduction to many in the room. He's a global health leader whose work has spanned the Gates Foundation, WHO, UNAIDS, the World Bank. He's an expert health economist and was, along with Dean, one of the editors of DCP4. And then finally, to my closest right, Dr. Charlie Whitaker, who's also from UC Berkeley, He leads the Pandemic and Epidemic Threat Analytics Lab, PETAL, at UC Berkeley, and his expertise is in or spans infectious disease modeling, surveillance, phylodynamics, pandemic analytics. And so what we thought we would do with this session is maybe kind of split the time between looking back, what did we learn from COVID, what has the world still not learned, and then what does resilient preparedness look like moving forward? Conscious of Eran's reflection that we shouldn't over-index on COVID, but nonetheless, what are the important insights that we could glean from that experience? What does meaningful pandemic preparedness actually look like now in a world that's constrained by political fragmentation, less resources? Somebody mentioned climate disruption, declining trust. What can we learn as we look to the future? But before I do that, before we dive into these specific themes, I'm going to turn to Steph. What do you think COVID fundamentally revealed about the strengths and failures of our global health pandemic response? And how does DCP4, the pandemic work that you've covered there, help us rethink what future preparedness might actually mean?
That's a question you want to ask. Well, having done media training, I know I can just bridge to what I want to say. Well, that seems like more of a concluding question. Let me say one thing parenthetically, because I thought the previous panel was so interesting, and a couple of people mentioned that the next vaccine may not happen so quickly. And it just made me realize that it's been 42 years and almost a month since Margaret Heckler, then Secretary of Health and Human Services, stood up and said, "We have discovered the virus that causes AIDS, and within 2 years we'll have a vaccine." So just something to think about. What I wanted to do was to say something about how we think about the cycle of the pandemics appear, and to get back to your question. And what we did in the volume, and you'll see it if you look at it in the introduction, you'll see it also in our chapter, is to draw a circle of what happens. So at the beginning, we have prevention, which is trying to stop pathogens in animals from infecting people. And Eran and I were just chatting, and I said, yeah, people who harvest bat guano should wear masks. I mean, right, that's the kind of thing that just makes sense. The second phase around the circle is preparedness, which means being ready when that happens, right? When there's spillover to people, when there's a small outbreak, are you ready to put the genie back in the bottle and get rid of it so it doesn't turn into a larger epidemic or a pandemic? And we're not that good at prevention, but some countries have been very good at putting the genie back in the bottle when it happens, and we know how to do that. So that's a really important part of the thing that goes through the book. Then you have a trigger event. An outbreak happens, and you need to respond. Now, that's what we call in the volume the early response. It's when you're responding to try to put the genie back in the bottle, basically to take this outbreak and make it go completely away so it doesn't turn into a pandemic, right? And very importantly, everybody in the world is interested in making sure that happens wherever the outbreak occurs, right? So the whole world is interested, whether it's in Liberia or the Amazon or in Papua New Guinea, of making sure that that response is effective. And then at some point, the horse is out of the barn, and there's no more ability to make it go away. And then the whole world's interest changes dramatically, because suddenly it doesn't make nearly as much difference to the United States whether somebody in Liberia dies of the disease that they're infected with, because it's no longer of self-interest. We may want to contribute for humanitarian reasons or for strategic reasons or whatever, but it's a completely different game once it stops from being containable to uncontainable. And so this idea that you have these sort of points that transition from prevention to preparedness to early response to late response, and then really a Dean suggestion, we talk about reconstruction, because what happens when it's all over, and you have, to Eric's point, school children that need to be re-educated and et cetera, and how you should pay for that. And I think that sort of keeping that circle in our minds and thinking about what various people here are going to talk about when it becomes important, and then what if you ask me, I'll talk a little bit about is who should pay for it, right?
Well, maybe before we move on, maybe you could speak to that briefly. It's clear that in investing in that first stage, and preventing before it spreads makes the most economic sense. How do we incentivize sovereign nations, particularly high-income countries, to do that, particularly in this moment where there doesn't seem to be political will for that, and resources are scarce to invest in that?
Well, I'm a closet prevention skeptic, as Eran pulled out of me just before the panel. I don't think there's that much that we can do to prevent the spillover events other than the obvious things. The other thing that we can do is to reduce the likelihood that when there is a spillover, that the reproduction rate, the number of people who are infected by each infection, it can be lower. So when my grandmother went to school, schoolrooms had big open windows, not just to the outside, but over the transom, so that the air went through and out the corridor and into other classrooms and out. If you go to San Quentin, which was built at the turn of the last century, you see giant open windows on the cell blocks because it's on the bay and you get cross ventilation. Those things were done to reduce the risk of tuberculosis and other respiratory pathogens. Nowadays, you go to schools and they're hermetically sealed. Turned out to be, those hermetically sealed environments, prisons where I was working, really bad. San Quentin 20 years ago welded shut the windows. So when COVID came along and they put people in there, you basically, it was like, infecting rats in a cage. It was incredibly efficient transmission. So I do think there are things you can do on the prevention side, but we're not going to stop spillover events, as we've heard from Nita and everyone else. I think we need to pay much more attention to what can be done in preparedness, and to realize that it's everybody's game. So we need to pay attention, and Nita will tell you what the pieces of the world are that are highest risk. All of us, no matter where we live, even if you live in Iceland, you are interested in Liberian preparedness, right? And then, I'll give you the answer of the basic answer of our chapter, is that the global health financing community, the stuff that finances global public goods for our mutual benefit, is really set up around financing things that need to be spent every year. Vaccinations, health system strengthening, maternal and child health, reduction of mortality from postpartum hemorrhage. All those are things that are predictable, that are annual, et cetera. What happens with pandemics is that it breaks that mold. It's the tsunami model. It's the rare event that requires immediate response. And even the pandemic fund at the World Bank, and we have a number of World Bank alumni here, that pandemic fund is for preparedness. Mm-hmm. It's not a mechanism that's designed to respond quickly to a new epidemic that threatens to become a pandemic so that it can be put back in the bottle. And I think that we really need in global health, the Global Fund doesn't work that way. The Global Fund responds to country proposals for rolling investment. We need the equivalent of, if you're a homeowner, you might have a home equity loan that's pre-negotiated. You can pull that money down anytime. We need mechanisms like that that are triggered by transparent, verifiable and the other chapter that Nita is involved in is a trigger chapter, which is how do you design these triggers so that the whole world knows when they're met, and then the funding flows automatically. And we need to be unafraid to let that happen, even if there are constraints on the country for what they can spend it on, right? If they don't end up closing the airports, you don't get compensated for the cost of closing the airports, and you can't spend it on something else. But having those mechanisms work quickly and efficiently so that countries are able to shut things down is really important.
Thanks, Steph. Maybe if we have time, we can circle back on that. I think it's a really interesting idea. I wanted to shift from thinking about the financing side to the systems response to pandemics. We have a nephrologist who is here talking about infectious diseases.
Totally.
Right. So I think
Good at that.
Shuchi, it'd be really interesting, both from your clinical experience, but also as a chapter author, how should we be thinking about pandemic preparedness and response in the context of other non-communicable diseases, and particularly, what do you think are some of the lessons from COVID that we didn't fully internalize as it relates to broader health system?
Yeah, well, thank you for having me here. I'm a chapter reviewer, and next time I'll be an author, but previously I was an editor, so I have a long relationship with DCP, but thank you for inviting me. And yeah, I think, and Dean may disagree because we started to chat about this before, but for me, the main message about acute care preparedness is actually a really hopeful one. It's really a win-win scenario that, as far as I can see, because it's actually a really rare win-win scenario in healthcare, because for most of the developing regions or low resource settings where we are worried about pandemic preparedness in acute care settings, what they really need to do is invest in their first level hospitals. That's the most cost-effective intervention that can be available for these settings. And that's fantastic, because that's really just healthcare capacity building, right? We need basic labs and diagnostics so people can be triaged appropriately. We need a skill set driven health workforce, so not people bounded by their labels, like you're a doctor and you're an RN, therefore you can do this task and others cannot. We just need a skill forced set of labor. And so that is just healthcare capacity building for countries. And it's really not a trade-off. It's health for everyone, and doesn't necessarily need to come under the level of pandemic preparedness, but does help prepare those regions for a pandemic. And that's the example of Liberia. If they have a nicely staffed first level hospital, they'll be able to put the genie back in the bottle, and they don't necessarily need extra capacity to do that. That was my one major point that I got from the chapter. The other one, I think it's very personal for me, is that routine healthcare cannot be delayed during pandemics. 8 million people died because they had healthcare needs that were delayed and therefore had life loss. And that's really what I take care of. A subset of people that I take care of are people on dialysis. And so they need a regular interface with healthcare 2 to 3 times a week. And we cannot delay their healthcare. And so there needs to be just a parallel system operating that also provides routine healthcare. Those were the 2 key things that I took away from the chapter. Mm-hmm. I think a third one that maybe wasn't addressed as much, but is important, I guess I want to see how many people actually went into a hospital during the early phase of the COVID-19 pandemic. Yeah, I took care of patients there. George was there. So we were caring for patients, but we were not doing well as healthcare workers. We had this emotional response that no one was managing, right? Because not only were we being asked to do more with less, less resources, and make decisions on the spot that were rationing, which we were not used to at all in the US, right? But also we were being told different things, and told those things in a very absolute declarative manner, like do not wear a mask. And then a week later, you must wear a mask. You must wear an N95. Or we don't have tests, so you cannot get tested. Or a week later, you must test every day. So it was just confusing and bewildering. And as someone who was a rule follower, you don't go to medical school if you break the rules. I was a rule follower, but my trust was completely eroded during that time. And I felt like I had to make decisions on my own rather than, believe public health messaging. And so that part really does need to be addressed. It was already brought up that uncertainty needs to be expressed in a better way. And I think that's a key message that people who are healthcare workers working in acute settings need during a pandemic.
Why do you think oxygen is so invisible?
That's a good question. I don't know the answer to that, except we just presume it's there. It's something that we just take for granted. We just always, I've never previously encountered an oxygen deficiency, never. So and even in low resource settings, you usually have oxygen. Like I've gone to Mali in the ICU, there's oxygen, there's not ventilators, there's not the positive support, but there's oxygen. Yeah, it's just not been something that we've ever thought of as being a weak link in the supply chain.
Dr. Desai, Angel, you're a clinician and epidemiologist. From your vantage point, what capacities do you think actually matter the most in the first days and weeks of a real outbreak? Again, from your experience during COVID and as it relates to some of the insights from DCP4. Yeah.
Okay, perfect. Great. Thank you. I'm not a rule follower. That's probably why I struggle. So it's a really good question. And so I want to just reemphasize something that Shuchi mentioned, which is, which I also took away from the chapter, which is this idea that when you're preparing for surge capacity needs, which hospital systems do all the time, really, because we know with some predictability that right in the winter, at least in the US, we're going to have a lot of cases and hospitalizations for influenza and RSV a little bit later in the season. And so we do have to have plans in place. I think one of the issues that we ran into is that when you encounter that moment of needing surge capacity, you need to have an off-ramp to be able to continue routine clinical care. I think right in the low and middle income country setting, there were folks that work in TB control that were being rerouted, and also, gene experts that were being repurposed for use in the COVID-19 pandemic, which makes sense. But as a result, right, years later, we now see all of these cases of TB that were delayed for diagnosis and for care. And similarly in the US, right, we've had you can see so many papers have been published about delays in cancer diagnoses and, diabetes and just all of that. And so I think it's important to be able to have those parallel processes, as you mentioned, because it really does put an additional strain on the healthcare system, on a hospital setting, even past the point of, when you declare a pandemic to be over. The second issue I think I would raise, and kind of piggybacks off of this question related to preparedness, is that when you're thinking about a hospital system, for example, being prepared, it is incredibly, and this is in the intra-epidemic period, it is incredibly resource intensive and time intensive to be able to do that. And I think there's also inequities based in that, baked in that rather as well. If you look at, for example, a hospital system in the US, a medical center that has the capabilities to take care of a patient with a viral hemorrhagic fever, there are layers and layers and layers of PPE that are required. There are, specialized respirators that you need special training to be able to use. There are so many policies and protocols that need to happen. And again, all of this stuff has a shelf life. So you need to continue to do the trainings. You need to continue to purchase the PPE or have dedicated equipment to care for those patients. And of course, we know in resource constrained settings, that's not the case. That's, their lack of PPE or availability of such supply chain issues, all of these things make a huge difference. And so I think that is a challenge actually to preparing for or being in the midst of a surge capacity scenario is all of that work that needs to be put in prior to that moment. It's really challenging for any healthcare system or medical system to be able to do on a regular routine basis.
So what does meaningful surge capacity look like for a hospital in a low and middle income setting then?
I mean, it's just a great question. So I think it depends on the context and it depends on the pathogen too, really, right? And so, and I will say that I think there are a lot of things that folks do way better than we do. And I'll take like a good example of this would be actually thinking about PPE. Now we need a base level of PPE for certain high consequence infectious diseases. But if you look at certain outbreak scenarios, for example, there may not have been actually very many nosocomial cases, even within these low and middle income settings. And yet here we're, required to have all of these layers of PPE and training, et cetera. And really like the basic, so I'm a hospital epidemiologist at heart, and also that's my main job. And so it's like the basics, the fundamentals that we just don't do well. Wash your hands, standard precautions, all of these things that I think, other contexts that are, I think, faced with these situations with more regularity do much better than we do.
Excuse me one second. Sorry, my phone is buzzing in my bag behind Dean. That's what you can hear. Charlie, I'm really curious to hear about the analysis that you contributed to in the chapter. But one thing that we talked about beforehand that I'm also keen to hear you speak to is the reality that actually during COVID and since then we've developed extraordinary technical abilities related to pandemic detection. Wastewater surveillance, metagenomics, AI-enabled forecasting, those kinds of things. And increasingly, my question is, the bottleneck may not be detection of the disease itself. So what happens when surveillance capacities outpace the ability of public health systems to actually respond effectively?
Thanks for the question. Delighted to be here. Thank you, folks, for having me. I think a kind of recurring theme in our chapter was that the information these systems generate can't be considered in isolation, and you have to understand them in the context of the decision making they can support. And the architectures for that decision support have to be in place ahead of time. And so I think, I would say we're in a really exciting moment for surveillance. Wastewater, I think, really had a coming of age moment during COVID, going from something that I think fair to say has been predominantly used almost exclusively for polio outbreak detection in a kind of presence-absence manner to something providing real-time quantitative population level signal across hundreds of locations around the world. And I think layering on top of that other developments, both during and since the pandemic around metagenomic sequencing, which is pathogen agnostic, you don't need to know what you're looking for, which is exactly what you want for the next threat, which the ones we're probably most worried about are the ones we've never seen before. And so the confluence of those two, unbiased sequencing and environmental samples, I think is possibly the closest thing we have to a true early warning system, which is really exciting. But I think, as you kind of alluded to, there is a tension there, which is that information is only informative when someone can act on it. And imagine, for example, a metagenomic sequencing system flags a sequence in wastewater across 3, say 5 cities overnight. 15% divergence from the closest influenza strain that we can find. And I think there's a question there of like, what should we do? What should we actually do in response to that? Are we concerned? And part of asking are we concerned is a technical question, but I think there's also a systems question there about, what happens Monday morning, who interprets what's been flagged, at what thresholds, whether that's geographical spread, percentage divergence, or some other metric. I don't necessarily have answers here, but what threshold triggers what response, I think, is really important. I don't know that we have a good answer to that currently. And so I think the real challenge for the field isn't just generating more data. It's being deliberate and thinking very kind of carefully about what data we generate, who's going to use it, how it gets translated into a structured risk assessment. And I think critically that decision-making infrastructure has to be built now. There's lots of really, really exciting movements towards expanding, say, wastewater surveillance across the US. But I think in parallel with that, public health architectures to action that information and actually support response capabilities has to happen now, not when the next pandemic is underway. And I think that means frameworks designed for folks who don't spend their day like I do, knee deep in computer code, analyzing like billions of reads. I think it means trained people at a variety of jurisdictional levels who can interpret a signal and act proportionally. I think it means exercises like tabletops ahead of time. And I think I'm relatively new to the US. I only moved here about 8 months ago, so I don't want to speak too much for the US, but I certainly in the UK and elsewhere around the world, I think we're typically much better at buying sequences than we are at building the human and institutional kind of enabling infrastructure around them. And so I think the piece I would argue here is that investment into those capabilities is almost as, if not more crucial than whether we're sequencing wastewater for another billion reads worth. And so I think that's the crucial piece.
From a cost point of view, where is how does that break down? Is that a multiple of investment over and above that technical capacity, or are we actually talking about a relatively modest investment in the expertise to
Yeah, it's a great question. I full disclosure, I'm not a health economist.
Sure.
So I might punt the question, but I would say I think my intuition currently is it probably would be a relatively small fraction of the sequencing costs required. That might change a little bit if sequencing costs continue to decline as they are. But I think my suspicion would be that this could be one of the highest leverage things we could do from a cost perspective.
Thank you. Shifting gears a little bit, what I was hoping we could do now is really think about, how we look to the future. What did we, to Dean's point, what did we maybe overlearn or underlearn during COVID? Did we become too focused on pandemic-specific systems? What parts of the preparedness agenda remain absolutely essential, and what are chronically underfunded? I wonder if any of you have an answer for that. Yes, Shuchi, go for
it. I think that one of the challenges when we talk about pandemic preparedness is when you talk about that with an under-resourced setting, like I work in Sri Lanka, they can't deal with the needs that they have in front of them. And then to think about it as a excess supply storage issue that might then expire, that is really tough case for investment. That is a really incredibly tough case for investment. And so really need to shift the message to let's catalog what you have. Let's have a live catalog of where you have what and how you would create processes to triage rather than create this expectation that there will be a stockpile of supplies.
Steph, go for it. And then
I think one of the things that was mentioned briefly in the last panel is access to materials when and if we need them for a pandemic. And I would say that now with multiple rounds of global health emergencies, anybody who's still optimistic that rich countries are just going to share scarce vaccines or other things with less risk countries is really, the definition of insanity. So I think that one of the things that's mentioned, and to be honest, there's really a missing chapter on how this should be accomplished, because I think there's a bunch of work that needs to be done. But I'm convinced that we need to decentralize manufacturing capacity, less urgently R&D capacity, because R&D know-how is more readily transmittable. And there are even existing, the TRIPS Accord and other things that potentially enable intellectual property to be harnessed in an emergency situation. But that's useless if you don't have regionally based manufacturing capacity. And, Dean mentioned at the beginning that we can't count on global leadership. Well, we have to look to regional efforts. And it's ridiculous to think that every country would have their own vaccine manufacturing capability. That would be ridiculously inefficient. Probably no country is going to be able to produce vaccines as efficiently as India can. But there's a reason why Latin America should have its own manufacturing capacity. And I would argue that it should probably sit in a place like Costa Rica that can't consume the large proportion of the output. Probably shouldn't sit in Brazil for the same reasons that the Indian capacity was consumed by India long before it got anywhere else. But to make that happen, the region has to commit to buying routine vaccines at a slightly higher price than they would buy them from India to keep that manufacturing capacity active. Because what I learned as we were doing some research for the book, talking to industry experts, is that there's no such thing as standby warm capacity in Costa Rica. You can't build the plant and equip it and expect that when the need happens, it will go. And the reason is because the scarcest resource at that time are people. And the people aren't going to move from Denmark to Costa Rica to start up production of something that's barely warm, right? So that it has to be ongoing used manufacturing capacity that can be diverted to that particular use And in the meanwhile, you put the veterinary vaccines on hold and you put the routine vaccines on hold because you've got stockpiles, et cetera. Right?
And Joe, did you want to go?
I'll figure this out by the end. So my answer is maybe a little more abstract, but I think so important, which is I think that having a One Health approach to pandemic preparedness or understanding is so critical. We don't do this well in academia. We don't do this well in government because everything is so siloed. And when I say One Health approach, I'm talking about the intersection of health of animals, humans, and the environment, and how they all link together. There was the seminal paper, and it's the one I always refer to in Nature in 2008, Jones et al., right, where they documented where most emerging infectious diseases are coming from. The majority of them are from a zoonotic origin, and most of those are from a wildlife origin. So, like, understanding that, I think is just so important, engaging with all of these other disciplines to be able to better sort of prepare, I think is so important. I say this as my amazing postdoctoral scientist is in the audience and is one of the authors of the One Health chapter for the DCP4. But, these are stuff we talk about all the time, right? And I think a great example of this where it can work well is, it worked a little bit well, is in the setting of H5N1 when we look at sort of we've got all this evidence that 2344B, that clade 2344B has the ability, has enhanced mammalian adaptation because it's infected all of these mammals, terrestrial animals that were not previously known to have been affected in the past. And so you can see there have been all of these efforts at UC Davis, right, to think about how we can work with the folks that work in the agricultural school and the veterinary school, the folks that look at the health of dairy cattle that have been profoundly affected in the regions, particularly in Central California, to look at that, to be able to work then with the folks that work on dairy farms, for example, the workers, to be able to make sure that they have the appropriate PPE. I say it didn't work that well because I think there's a lot of practical issues there, right? To be able to wear that PPE to prevent potential transmission from an infected cow. It's insane. I mean, it's just, you need all of the face shield. There's so much there. It's very difficult to actually be able to do your job in that. So there's a lot of issues with that, but I think I think it's certainly underappreciated, maybe more so now. But I think just being able to have these cross-disciplinary discussions so important.
Thank you, Charlie. I don't know if you wanted to respond to that, or I can prime you with another question.
Yeah, I just wanted to really briefly echo Steph's point, which I think the area in which I think we're most underfunded is ways to prevent the kind of moral catastrophe we had around medical countermeasures. I think it's ridiculous that my parents in Southeast London received the vaccine about a year ahead of my medical colleagues in Colombia or Malawi. And I think I'd be interested to get some takes from the audience here as well in terms of potential solutions to this. I think I've been quite excited to see some market-based mechanisms emerge. There's the African Vaccine Manufacturing Accelerator, which is attempting to be a kind of advanced market commitment to onshore a lot of vaccine manufacturing. I think there's some concerns there about whether a lot of the places that get established will end up being kind of fill and finish rather than the full workflow for vaccine manufacturing. It's been quite exciting to see increased investments into places like Instituto Butantan in Brazil or Institut Pasteur de Dakar in Senegal. But Instituto Butantan's production capabilities for the chikungunya vaccine is probably going to be about 3 million doses this year for a country with many, many times more people. And I guess the question I would maybe put to the audience is, how far do we think market mechanisms can get us? I think people have alluded to reservations around the pathogen access and benefit sharing system in the WHO pandemic agreement, but I'm interested to explore potentially a plurality of options from a diversity of different ways to try and get at this issue, because I worry that market-based mechanisms might be a bit insufficient on their own.
Thank you. Well, that is a great prime. Would love to take questions from the audience. Before we do, I will ask our panelists one penultimate question. And And that is more of a sort of a hopeful, optimistic question. You know, what gives you hope as you think about, you know, the response to the next pandemic? Clearly, we shouldn't be optimistic about a pandemic, but like, where do we think there are opportunities for success in how we respond? Shuchi, can I call on you first? Yeah.
Two points to make there. One is that because of climate change, we have many more frequent little pandemics when we have disasters, right? They usually need surge capacity too, whether it's wildfires or the heat wave in Phoenix. We need, capabilities around dealing with those types of disasters. And those hopefully will help us care for a pandemic, which will be a larger surge. And the other thing that is a train that's moving and will hopefully be moving in the right direction is the use of AI in decision making, and also the video visits, because I personally hate them. But if a pandemic occurs, a video visit paired with potentially some AI decision making with diagnostics and lab capabilities can really save resources. And hopefully that will be a positive development that doesn't need a lot of touch and care and is just already being market driven and into the world without our assistance, really.
Great, thank you. Michele, any thoughts? Yeah.
I think it was sort of said earlier, but some of the technological advances, and we've talked a little bit about it here, give me a lot of hope. I think metagenomic sequencing is amazing, fantastic. We use it not only in a local hospital level, but also genomic sequencing in general. If you can do it so quickly, even with short sequences, in some cases, I think, that gives me a lot of hope in terms of being able to understand potentially the origins of a pathogen, the similarities to other pathogens in that family, but also ways in which it's potentially evolving. That's maybe the very sciencey answer, but.
Well, first, I'm the eternal optimist, and I do believe, I heard somebody talking the other day that to get an arrow to fly far, you have to go backwards first. And you have to put the world or the situation under tension. So I choose to believe that we are not in a spiral into hell, but rather that we will hit something and then rebound even more vigorously. So I choose to be optimistic. I'd like to think that my grandchildren won't live in the seventh wonder of hell. And the other is that I am a technology optimist, and I think I'm even a huge AI optimist in terms of what it can do for scaling access to high quality care. I know my ability to read a chest X-ray, and I went to medical school a long time ago, and the computer got better than me, a long time ago. It got better at me at reading an EKG as well. I do think that there is huge potential there, not so much here, but in places where the community health worker is equipped with a toolkit and can do so much more. But the other thing I'm optimistic about on the technology front is what it can do to accelerate science. And, when we have a new pathogen, we are at the brink of the computer being able to tell us what the structure of the monoclonal is that will neutralize that pathogen and that won't bind to other proteins in the body. That kind of thing, I think, can significantly accelerate. What we saw with the mRNA vaccines was, made possible because of new technology. And so I always, early in the AIDS epidemic, I used to talk to my patients about escalators going down and escalators going up. The escalator going down is that they're getting closer to death every day. The escalator going up is that technology is creating solutions that can keep them alive. And, many of my patients died way back then, but many of them survived long enough to get on drugs, and they're still my colleagues today. So, I think we're in this race, but I'd like to think that technology can be our friend.
Yeah, thanks. Charlie.
Thanks, Steph. I'm conscious we're running a little bit over time, so I'll keep this brief. The world is a big place filled with lots of good people, and government's far more efficient than the one currently running this country. And I think at a time like this, I've been really grateful to my international collaborators who operate in settings where there is significantly more public trust and investment and willingness to make material gains against some of the threats we've described today?
Thank you. Well, love to open up for questions. If there are any, I see Professor Rutherford has his hand up. Robert, do you want to?
Thank you, Erik.
Thank you. Steph, it's interesting you mentioned guano harvesting. I don't know if people know this, but that was the cause of the greatest epidemic of the 19th century, which was Phytophthora infestans. Now, nobody knows what that means, but it caused the Irish potato famine. We were mining guano in Peru and bringing it to Britain for munitions manufacture. So just a lesson there. But speaking of munitions, I just wanted to raise the issue of engineered organisms and how the chapter is dealing with that, or how you guys think about that, because we can talk about goodwill and everybody pulling in the same direction, but if there are people on the other side pushing, it raises a lot. It makes it a much more complicated.
To add to that point, presumably AI makes that even more a possibility. Was that something you addressed, or was there any kind of quantification of the threat posed by genetically engineered pathogens? DCP5?
I mean, if you look in the introductory chapter, you'll see that it's a relatively low-cost intervention because there are relatively few labs to prevent accidental spillover from labs doing work that is dangerous. It says even less about what to do about state actors or non-state actors that are going there intentionally. And I think it does make some mention of the need for intelligence and surveillance and enforcement and things like that, but it is a really hard nut. And not just the AI making it easier, but also laboratory techniques that are making it easier.
I think it's a really important question, and I think to maybe some of what Nita was discussing on the previous panel, I think anticipating and trying to spool forward in time these both ecological changes related to climate change that we've talked about is probably going to be increasing the frequency of zoonotic spillover, but the complex technological changes that feel like they're changing on an even more rapid timescale feels very challenging. And I'm increasingly wondering what that preparedness, prevention, response framework would look like in the context of deliberately engineered threats. So, for example, lots of people have been thinking about DNA synthesis screening as a mechanism to try and limit the ability for folks to get a hold of potentially dangerous nucleic acids. There's been talk about guardrails for large language models or biological design tools, which often come from the less large language models, but biological design tools typically come from the scientific, endeavor, which tend to be more open source, which is great in some ways, like challenging in others. I think establishing guardrails around that is possible, but very challenging. People have spoken about us applying the equivalent of BSL 1 through 4, but for data, thinking about the types of data we make available. And again, I think there are tensions here between open access and what they could potentially enable. And I think there's a broader question here about, do we aim to target specific interventions at a particular class of threat scenarios like engineered pathogens, or do we try and improve the resilience of our society to withstand these health shocks? I think one thing that immediately comes to mind that we've all, I think, alluded to is how terrible air quality is in schools. Imagine if all schools had great ventilation, upper room fire UVC or something similar. What could that potentially mean, not just for naturally occurring threats, but engineered ones as well?
And the regular stuff that.
And the regular stuff.
Oh my God.
So I think there are co-benefits there.
Can you hear me? Okay, good. It's hard to tell. I don't know if this is a reasonable question or not, but is there such a thing as a baseline today of what's happening relative to pathogens or viruses and what the trending is at the moment? Using wastewater, using some of the other methods. Is there any real-time monitoring across different states, what have you? I mean, is that an unreasonable ask? I don't know.
You have to answer that question. You need different than mine.
Yeah. We'll ask you to ask that. Yeah.
Yeah, so there are programs across several jurisdictions in the US. It's mostly led by the National Wastewater Surveillance System, which is run by CDC. Now, there is some funding issues related to the current congressional budget kind of impasse, but that is occurring, and there's also efforts going on through Stanford wastewater scan. And so, full disclosure, I currently consult with Verily, and so we do run about over 150 of those sites that are run at wastewater treatment plants, and we're testing for about 30 pathogens. So there is some ongoing work there. I think funding continues to be a challenge, and so that's something that we're carefully monitoring. There's also what Steph alluded to, which is another CDC program called the Traveler-Based Pathogen Genomic Surveillance Program, where there's nasal swabbing and wastewater testing happening at certain airports in the US. So there are programs like that happening. The data are coming in, and I think it's kind of to Charlie's earlier point, which is that it's still not always clear what to do with all that information. So it's actually one of the things I'm currently working on is how do we develop insights and how do we make decision-making playbooks that can actually, lead to some kind of actions and activities that stem from that.
Oh, yeah. That was very strategic. Yeah. I'll just add to, this is actually something we just talked about in terms of like the early warning system sort of infrastructure. There's also, people who are probably familiar with ProMed, but there's also Beacon Bio, or Beacon right now. It's based out of Boston University. And so they have subject matter experts all over the world that work to try to identify and provide risk assessments essentially of emerging threats. Through folks that are on the ground, through extracting information using AI, using an LLM actually from social media, from the news, et cetera. And that's openly available, open access for folks that are interested in that. And then I will, I don't want to put a plug in for this, but I will since we're here. So at UC Davis, the One Health Institute, we also have a program called the Virus Intelligence and Strategic Threat Assessment work that it's supported by the Coalition for Epidemic Preparedness Innovations. And that goal is actually to try to bring all of this kind of information together to provide sort of risk profiles for zoonotic pathogens that exist all over the world to, provide some of this actionable information, hopefully to folks that may find it useful.
Great. Well, thank you to our panelists. We will do this as a group discussion. They, I believe, will all be around afterwards, grabbing a drink. So please, if you do have questions that weren't answered, find them.
What an incredible conversation. I'm sure you're all going through all sorts of emotions having heard those two panels. I know I am. So that's the purpose of this next final segment. This is going to be a conversation with two deeply experienced thought leaders in our community in global health and pandemics and social justice and a whole slew of issues that interact on the things we've been talking about. And I'd like to bring up and welcome Dr. Michele Rampele, who is well known to many, but I'll share a few things. One, we're delighted that Dr. Rampele is with us here at UCSF for the last year as a visiting scholar, working on a book, teaching seminars to our students, and has been really an inspiring voice for us as we've been navigating this past year, and delighted to hear your voice about this. And then, of course, invite Ashish Shah, Dr. Ashish Shah, who many of you will know from the television and from other things, but he is the CEO of BioRadar and from the Harvard Kennedy School, and again, incredible experiences at the White House. And I thought this is going to be a dynamic conversation, no moderation, free will, just go, reflect.
Do you want to lead us off? All right. So this has been great. And I trained at UCSF. I love UCSF. So any excuse to come back to UCSF, I will take, but this one is a particularly good one. So thank you for having me. This has been a super interesting conversation, and the hardest part has been like not wanting to jump in on every part of the conversation because you came to listen to the panelists and not me. But I'm going to take a couple of minutes to talk about a couple of things. One is a story. So I ran the COVID response for President Biden, and after the winter of 22 into 23, it was the first winter where like things didn't go horribly wrong. You know, thousands of people weren't dying. I felt that it was time now to go and end the national emergency, end the public health emergency. So I made the case to the president's chief of staff, and then I had to go make the case to the president. So walked into the Oval Office, talked to the president, said, it's time. It's time to end the emergency. And that got us going on a conversation. He was just in one of those kind of moods where he was like, how do pandemics end? I'm like, that's an interesting question. Because there have been lots and lots of books written about how pandemics begin and how we should respond to the early days of pandemics, and very little written about how pandemics end. And he was curious, and that got me curious. And so I went back to my office and I reached out to about 10 historians, people who are historians of medicine and science. And I just said, hey, I have a simple question for you. Would you get on the phone with me or Zoom or come in and spend an hour and teach me about how pandemics end? Because we've had pandemics throughout human history. Fascinating set of conversations. A couple of insights. One of the historians used a line, which I'd actually read before, but I love, which is that pandemics end with a whimper, not with a bang. Pandemics begin with a bang, end with a whimper. Like they just sort of fade. But the one interesting insight from every single person I talked to, everybody had their own theory. I mean, get 10 historians, you're going to get 12 perspectives on anything. But the one thing everybody brought up is that after every pandemic throughout human history, an intense amnesia sets in, where for an extended period of time, there is absolutely no interest in thinking about pandemics, disease outbreaks, and all the things that people learn, they unlearn in the years that follow. Feel familiar? So in that way, it's both distressing and comforting that this period of time that we are going through is not unique to human history. Doesn't make it any easier or better. Still a problem, but it is helpful to understand that we're not doing this for the first time. One other thing I want to just quickly talk about, because this becomes a little bit of a diversion, but it's been brought up a couple of times. So for the last 2.5 years, 3 years, I have been spending almost all of my time thinking about biosecurity engineered pathogens. Most people in public health are not, I think, kind of privy to and have not sort of understood the intelligence of where this field is. I think in the last 6 to 12 months, you started seeing more and more public stuff. That New York Times article from a couple of weeks ago, basically acknowledging what has been understood in the intelligence field, which is that there has been this massive investment in building of engineered pathogens by both state and non-state actors, enabled by CRISPR, synthetic biology, and increasingly artificial intelligence. There was an entire effort inside the Biden administration to say, could we put in guardrails? I have been deeply, deeply skeptical of any guardrails that are going to prevent this. They might slow things down by weeks or months. They're not going to slow things down by years. And I very much appreciate the modeling of natural threats. And, you know, as I was saying earlier, all models are wrong. Some models are useful. That's a useful model, right? Like but the last point is that in my personal view, I think the chances of an engineered pathogen being used against a human population in the next 5 to 10 years is close to 100%. Like, I just don't see a world in which that does not happen. So the urgency of getting going on building systems for natural or engineered pathogens is about as high stakes, I think, as anything that we could be working on. And so it has, and by the way, that was, I think, pretty well understood inside the Biden administration. It has been it is understood well inside the Department of Defense in the Trump administration, but large parts of the Trump administration is largely blind to it. And I think not enough not enough other countries are aware of it and are acting with the level of urgency that is needed. If I managed to just depress the heck out of everybody, I think we have solutions, by the way, so we can come back to those. But I think that any conversation about pandemics at this point in history have to have a conversation about biological threats that are natural, accidental, or engineered, because to me, all three of those are very high likelihood events in the years to come. But we've got lots of solutions. But I'm actually going to stop because I want to hear.
I just want to pick up from where you left, but in a very different direction. We talked earlier on about what's happening to the global health system and whether you can continue to rely on the institutions that were set up 50 years ago. Definitely not. But what we must rely on are the millennia. When you look at the population of the world, you actually, at least in my part of the world, in Africa, you are the majority. And I belong to a generation that was a minority, but that started a way of thinking that changed the way my country, for example, was being governed. There was a sense that, Margaret Thatcher said, whoever thinks that there'll be an end to apartheid is living in cloud cuckoo land. Who is now, right? So you can, in fact, change things if you're prepared to think differently. And you think differently, not from a position of comfort, but a position of non-comfort. And so I want to make the first point directed at the younger generation. You have more power than you think you have. And you have access to technology that we didn't have. But we did change the world. You can change the world much faster. Exactly the same uses of technology that were talked about here can be turned to be uses for greater benefit. Having said that, I think when we're talking about pandemics and preparedness, are we factoring in that the very technology and the resources that are used to produce AI and all of these technologies are actually indirectly, but in some cases, as in the case of the DRC, which is now facing this another zoonotic disease, is the rare earths that are mined in areas that were covered in forests for ancient, since millennia ago. And somehow we have a president in this country who is saying to the likes of the DRC or to South Africa or to Zambia, allow us to mine and then we can give you money, that 5 cents or $5 for AIDS. So when we're talking about prevention and preparedness of against pandemics, we must start at home. You as the voters in this country must start saying to your people in government, in Congress, and in the White House, you are going to be the cause of zoonotic diseases that will make your genetically engineered viruses look like a school picnic.
I want to pick up on that last point, not about the engineered pathogens being like school picnic. So I think we can all agree we don't want either engineered or. I made this point earlier, and I think it is important. It is very easy. I'm not a huge fan of Donald Trump. Just want to put that out there from in case anybody's wondering. I think he's actually a terrible precedent for our country. But I see him much more as a symptom than as a cause. So he is a cause of a lot of problems too. But I think we make a mistake if we only see him as a cause, because I was making this point earlier to a small group of folks. If you see him as a unusual, once in a century, once in a whatever, evil agent, then you say, okay, well, we just got to survive now another 2.5 years, and then we'll get better. And what I have been saying for a while is that when we look back at history, Joe Biden will look like the anomaly, not Donald Trump. There was a 4-year blip where Joe Biden came in and it was more normal times. Which I, of course, find sad because I worked for Joe Biden. I thought he was an extraordinary president. But the point is, we're not in a rainy day. It's not a storm that we just got to get through. This is climate change. The world has changed. The institutions that I grew up believing in, CDC, WHO, they're obviously different, but WHO founded, after the end of the World War II. Those institutions just are not fit for purpose for the world that we are in now. My big fight with WHO has been that I have felt that there's an urgent need for reforming WHO for over a decade. I'm going to tell one very quick story. On the weekend of the inauguration of Donald Trump this time around, remember on Monday when he became president, one of the first things he did was withdraw from WHO. So that was coming for months. We knew since the election that was going to happen on day one. And a bunch of us did a bunch of things to try to prevent that. I was working with people on the transition team, actually trying to talk to people in the incoming White House, had conversations with folks at WHO saying, this is coming and you guys should be doing things proactively to prevent it. And much of the leadership of WHO was like, nah, he did that during the pandemic, he'll never do it again. And so the weekend before Monday, I wrote a piece in Stat News. I had written it a while back, published in Stat News, basically saying, reform WHO, don't leave it. Laid out a set of things that I thought WHO needed to change. And it was sort of my last effort to try to get the administration not to walk away from WHO. What was WHO's response that weekend? They spent the whole weekend writing a very sharply worded rebuttal against me. I'm like, dude, I'm some random academic. The president of the United States is about to pull America out of WHO. Like, focus your energy. WHO is like an agency. Again, I love WHO. I love a lot of the people there. These agencies are not functioning for the moment that exist. So I think the mistake we can make at this moment is to wish to go back to a different time. We ain't going back. The thing that we need to do at this moment is to understand the challenges and risks, look at them very directly and with open and clear eyes about why we are here, and then paint and build a much more positive vision of the world. Because if we don't, I think where we're headed is a world where everything is transactional, as you said. You let us mine your rare minerals and we will give you money for PEPFAR. That is not the world I want to live in. But the only way we're going to have an alternative is if we can all work together to lay out what that alternative is. And that alternative is not, let's go back to what we used to have.
I couldn't agree with you more. But I want to go much further than just simply what you said about Donald Trump is not the problem. He is a symptom of a system that was designed to fail. The democracy that the Western world has been selling us, the poor people, so-called undeveloped. I don't want to develop to become like this country. We need to rethink what democracy should look like. People quote Aristotle as the father of democracy. He said there are two types of democracy. One type is where you have an equal chance of every citizen through the lottery to become a representative. So you have a government of peers that you can hold accountable. What we have, not just in this country, but everywhere else, is money talks. If not the billionaires in office, but those who are in office are controlled by And I come from a very poor country where my government is a government that doesn't represent me because they've been captured by money, and they in turn have captured the state. Now, the state capture, which oftentimes when I was still at the World Bank, they'll talk about how corrupt Africa is. Africa is corrupt because it learned from Europe as the colonial master how to capture a state. And now you have a president of this country who doesn't do it under the table. It's just done openly. So state capture is the mode of governance of the Western world. And unless we change completely from that model, we will not have systems that we can say this is a global system where we care about everybody and we care about ecosystems that we have already damaged that are in fact showing us that we've got planetary emergencies, planetary crises that we have brought about. And so my plea with all of us, and this is where I go back to the younger people, you need to raise your voices about the irresponsibility of my generation and older generations in continuing on a path which can only lead to disaster. And this doesn't make me a pessimist. It makes me a realist. And I'm saying we have an opportunity to rethink democracy altogether, to rethink what it means to be human, because we were created to be relational as a species. We do fantastically well when we are surrounded by caring, loving, supportive relationships. And when we act that way, when we act against other people, we become terrible because we know that's not what we are supposed to do. The essence of being human is to be kind, loving, and not just to other human beings, but to all life. That's who we are. We have now adopted a way of being which is totally destructive of ourselves in the first place. Just look at the people who are dictators. They clearly don't love themselves and they have no capacity to love somebody else. So what I'm suggesting is that the problems that we are seeing in the world are problems of our own making. And they require not the removal of X or Y from power. They require a reimagination, a rethinking about what are our responsibilities as the human race. There are 4 myths that have brought us to where we are. The first myth is there are different races. There are no different races. We are one race. And this is not Mampela speaking. The geneticists will tell you that, right? 99.99% of our genes are the same. Why are you making such a big deal of this 0.00%? It's because it is functional to the system we have developed where we need to oppress or extract from somebody. Second myth is that we are born with a selfish gene. Have you ever met a selfish gene? It doesn't exist. But we have created it to justify why we can act without compassion, without empathy. The third myth is we say we are utility maximizers. And I know all these things because I learned from my colleagues at the World Bank. We are not utility maximizers because we feel terrible when we do that. We feel well when we share, right? And so we have created these myths. And then the final myth is that we have been put in dominion over the creation. Who did? There's no way. We are the last species that was created. We are the youngest species. We just are a destructive last born in creation. And so if we can address those things, embrace them, we are not responsible for them, but let's embrace them and find a way of rethinking what it means to be human. What a lovely world we'll have. You just watch what happened in Africa during COVID. They were saying, you're going to see corpses in the food bikes in the villages. You didn't. Yes, a lot of people died, but what came through? And even today, scientists cannot explain why the death rate was not as high as it. You know the difference? Because people can't. They watch that old lady who was sitting there, they open the door, Gogo, can I bring you this and that and that? Okay. I live in a suburb in Cape Town. My neighbors never bother about whether I'm alive or dead. But during COVID, they would lean over the fence. Manpela, I'm going to the shop, can I? So I'm saying, if only we can return to the essence of who we are, we can actually have a wonderful time.
Wow. I don't think I should really say anything after that, but I'll throw in a couple points. No, look, there are a couple of things to think about at this moment, which is I don't believe for the topic of today, which is how do we protect the world from outbreaks of infectious diseases, kind of writ large, right? Things that become large global outbreaks, pandemics, engineered, accidental, natural. I think at this moment, thinking that the solutions are going to come from government or they're going to come from multilateral institutions is a mistake. They are not coming. And I say this having served in government at the highest level of government, and having interacted with, at least when I was in the job as the COVID response coordinator, interacting with WHO, 3-4 times a week, usually directly with Dr. Tedros, having spent a lot of time looking at these institutions. I don't think any of them are going to be this. They're not the cavalry that's going to save us. So then you're like, well, who is the cavalry? And I would say we are the cavalry. Like, we've got to figure out our own solutions. I think there have to be private sector solutions. I think there have to be nonprofits that have. I take an organization like CEPI. It's doing extraordinary work, like having massive amounts of impact. There's lots of examples. I don't mean to highlight CEPI alone, but there are just lots of examples. There's other places I have hope. Like I think about what is happening to science on the continent of Africa. It looks totally different than what it did 10 or 15 years ago. And I mean that in a very positive way. This latest outbreak of Ebola got sequenced and uploaded within essentially 2 days, a day and a half, after it was kind of identified by African scientists in the DRC and Uganda, right? So there is a lot of great stuff happening that we have to harness. But I think it's a mistake to be overly focused on, should America go back into WHO? Like, yeah, they should. Are they going to? Probably not in the next 2.5 years. And is there anything any of us in this room can do to convince Donald Trump that he should? Boy, I have a lot of actually friends in the Trump administration. I talk to them. None of them can influence this. I can't influence this. I think we just assume that's not going to happen. Or maybe it'll happen for some reason. Who knows? But the point is, I don't even think it matters that much. I think the loss of sort of this kind of multilateralism means more growth of regional institutions. For instance, I think the Africa CDC is a huge step forward. And I've been a huge fan. We can talk about John Kaseya, and he's got some strengths and some weaknesses, but the point is, it's a great organization. There are lots of examples of new innovative things that are happening. And one, this is not a personal plug, like I left academia after having been an academic my entire life to go actually try to build the global biosurveillance system that I think we need, mostly because I came to conclude CDC is not going to do this. HHS is not going to do this. US government's not going to do this. WHO is not going to do this. No one's going to do it. And I just got tired of writing op-eds about how we need it and speaking on panels like I am right now on how we need it. And I just thought, okay, it's just time to go try to build stuff. So what I would say to all of you is think about, like, what are the big problems that you think that someone should be solving is not? And then figure out how you can solve it. Because waiting for other people to solve these problems.
Yeah. I just want to agree with you that we don't need to rebuild the multilateral system as it is today. It's broken, and it's been broken for decades. So what is needed is, again, a rethinking. I was looking at what is the proportion of the world population is the US. It's 2 point something percent, 2.4%, okay? So the global majority, we cannot not take responsibility. We have to take responsibility, which is why I'm pleased that the African continent, with its wobbly governments, but when below the governments or within the populations outside of these governments that are married to money, there is so much creativity, so much energy, so much goodwill. And what we need to do is not to waste our energy trying to reform the unreformable. We need to think anew about what kind of systems, what kind of governance do we need, not multi-party democracy, which has been sold to so many post-colonial countries, including my own. It's a dead end. It's a dangerous end because it swallows up whatever resources there are. Citizen assemblies are growing up all over the world. And I would like to encourage, particularly the millennial age group, look at how those work. Kerala is the poorest state in India in terms of GDP growth. Incidentally, I've got my big issues about GDP and what it measures or doesn't measure. But Kerala, in terms of the outcomes of human development indicators, is better than the richest. In terms of corruption, they've got a lower level of corruption. Why? Because they have citizen assembly type of government. So your generation's job is to reimagine, rethink, rebuild governments in a different way from what exists. What exists is broken, and let it just continue to disintegrate. You mustn't waste your energy on a process of disintegration. Focus on what you're good at, which is creativity, energetic reimagination, dream. There's nothing as beautiful as dreams. Thank you.
So by the way, we did not do any coordination at all, but we didn't. But one more addition to the last point. We've talked a little bit about misinformation and disinformation in the last couple of hours, and I want to take 30 seconds to talk about it because I've spent a lot of time the last 3.5, 4 years thinking about information, communication, how we manage. And what has happened to the information ecosystem that we all live in is it's gotten extraordinarily fragmented. The way to understand it is that every one of us has an information ecosystem that is designed for us specifically. The algorithms all essentially create highly individualized information ecosystems, right? My Twitter feed or Instagram feed is totally different from everybody else's in the room. A couple of quick points to just bring home how we build the institutions of democracy that you heard. One is there is a view that most people have that my information is like very rich and I look at all sides. But my political opponents, they all live in a bubble. Point number one, we all live in a bubble. Understand that. Second, because you live in a bubble, as I live in a bubble, we all consume some good information and we all consume a bunch of junk information. And our ability to tell what is good information and what is junk information is not as good as you think it is. That's humbling. But you should understand that your information feed has got a lot of bad information in it. I always remind myself that during the pandemic, in the first year and a half of the pandemic, I got a lot of death threats, a lot of harassment, all from the political right. In the second and third year of the pandemic, I got death threats and a ton of harassment, all from the political left. It was crazy. And we can talk more about that, like maybe over a glass of wine. But the point is that we all have lots of bad information that we consume and begin. So then the question is, what's the antidote to this? And the antidote to this is not regulating social media. That's not going to happen. I don't know how to make that happen. I don't think it's going to happen. The antidote is to start talking to people in real life who don't agree with you. So get out of our bubbles and start having conversations. By the way, to me, that is the most fundamental act of democracy too, is that you build coalitions by talking to people, finding common ground. I have been really pleasantly surprised. And I said I have a bunch of friends in the Trump administration. I do. I also said I find this president very, very difficult to deal with. And like this, but that's because there are lots of people with whom I have common ground. We agree on a lot of things and we work on those things. And places we don't agree, we just decide we're going to disagree. And occasionally we fight about it. So one of my last kind of requests to all of you is if we're going to build a stronger social fabric that's going to help us survive the next pandemic and all the health crises, we've got to do a better job of talking to people who think differently and have different ways of understanding the world than we do.
Thank you for an incredible, thought-provoking exchange. They're going to take the wine away, so we should probably run over there and tackle them. I'll make my closing comments very, very brief in that I think there's a common theme across the conversation that you just had and earlier panels. Is human psychology is critical to what we're talking about. And cynicism is a term that's 2,400 years old and comes from an ancient Greek scholar's school. And the cynic believes humans only make decisions based on self-interest. And we have to change that. And I come back to your lectures, Michele, when you arrived a year ago and told us that there's only one human family. And so until we can't get ourselves collected around that. So the DCP-5 suggestion is a chapter on human psychology and the philosopher's view of pandemics. If there isn't one already, then maybe there is. But anyway, I want to thank everyone for attending. I want to thank our speakers, our panelists, Dr. Michele, Dr. Ashish Jha. I want to thank the co-sponsors, UC Berkeley, Stanford, Bay Area Global Health Alliance, UC Davis. I want to thank the experts who wrote all these wonderful chapters that have enriched the conversation today.